So now we come to the cardioplegia more in detail. So to provide a motionless field for the surgeon, a potassium-rich cardioplegia solution is given into the heart to arrest the heart in diastole. So potassium-induced arrest alone will reduce the heart's myocardial oxygen consumption by about 90%. But still, there will be some requirement by the heart cells for its own nutrition. So what we do is this cardioplegia solution does not contain just potassium. It also contains blood and certain nutrients in order to replenish whatever the heart cells will, or the myocardial cells will require as part of the basal metabolism that continues to happen. So this is very vital for us to make sure that the myocardium is well protected throughout the length of the surgery. Else, after the surgery, when we try to get the heart back, if the myocardium has suffered, we will not be able to get the heart back to beat and contract optimally. Another thing that we do is to cool the patient. As we decrease the core temperature, the myocardial temperature also reduces. Hence, the further oxygen consumption or the metabolic needs of the heart and the rest of the body also reduces. So a potassium-rich solution and cooling, along with giving nutrients through the cardioplegic solution, are the ways that we achieve optimal myocardial protection while the child is on cardiopulmonary bypass. So cardioplegia can be given through two routes, I can say. One is the antegrade cardioplegia. So we give it into the aortic route. Other one is the retrograde cardioplegia. So there's something called the coronary sinus, which most of you might be familiar. So we give it retrograde. So we give it into the venous system of the heart. So it goes in the reverse direction and then it goes into the coronary arteries. But still the purpose is served. This is probably a little too much in depth for you all, but just suffice to know that these are the things that go into the solution. We give potassium, of course, soda bicarb, magnesium sulfate, lignocaine, mannitol. Each of them have various functions to play or role to play. There are many types of cardioplegia. In our center, we use Denidor's cardioplegia. So that's about it. About temperature, we deliberately achieve hypothermia because it's the best way we can protect the brain and the rest of the vital organs. And temperature is monitored by keeping a tiny probe into the nasal or the nasopharyngeal, esophageal, rectal, or skin surface probes. So depending upon the complexity of the surgery, we cool the patient accordingly. So there are times when a patient with 36, 37 degree temperature is cooled down to 30 to 32, which is generally the temperature in which most surgeries are done. But at times, as it goes more complex, we may go down to 28, 26. And there's also something called as deep hypothermic circulatory arrest, where we take the patient down even to 18 degrees or less. So it's a death-like state where all activity ceases and very minimal flow is given to the brain to keep it active and well perfused. And then we rewarm the patient very gradually back to the normal temperature. It's a state of suspended animation, I can say. So next is the heater cooler unit. So this cardioplegia, which I spoke about, gets cooled from the water or the bath, which is there inside. It's also called as hemotherm. So inside that there's bath. There are different tubs where you can insert water, and there is a way of cooling or heating this water. And those tubings with hot or cold water will warm the blood or cold the blood of the patient as required. These are the suctions. Like I told you, we don't really lose any blood in cardiopulmonary when there's cardiopulmonary bypass. So whatever blood is accumulated in the surgical field will go back into the reservoir of the CPB machine. And once it's filtered, it's returned back into the heart. So everything sounds good, but what are the adverse effects of CPB? So CPB, though it has facilitated a lot of surgery and treatment of complex heart diseases, we must remember that it can affect end organs, especially brain, liver, kidney. And that depends mostly on the duration of bypass. So because it's unphysiological, we need to keep it as short as possible. And of course, the age, like when we operate on a neonate, hardly like 5, 6, 8 days old, you know that everything is immature. The brain, liver, the kidney, everything is immature in a kid of that age. So they have more adverse effects of cardiopulmonary bypass than maybe a little older 5 or 7-year-old child. So for the perfusionists and anyone here who's interested how it goes, the heart-lung machine should be assembled before the scheduled surgery so that they're ready to go on bypass whenever is needed. Then we prime the circuit and we cannulate, and then we go through a pre-bypass checklist, which is read out by the anesthetist. Then the surgeon has to confirm everything is okay. Anesthesia confirms everything is okay. And the perfusionist also from their end confirms that they're all okay. It's something like flying an aircraft. So once everyone is on the same board, we say, okay, we go on. So we connect the patient to the cardiopulmonary bypass, and we stop the heart and lung of the patient and allow the machine to take over. So it has to be done seamlessly and without any mistakes. Otherwise, it could be fatal at times. So while the patient is on cardiopulmonary bypass, we monitor these things. One is the blood gas. So we have ABG machines in close proximity. So the perfusionist will keep giving blood samples to analyze so that they maintain the oxygen levels, the bicarbonate levels, the potassium, calcium, everything they have to maintain. They have to see that the perfusion is adequate. Inadequate perfusion will be reflected in the form of lactates going up. So they will adjust their perfusion accordingly. And sugars, if it's going up, it indicates stress. So it could mean that maybe the patient is not adequately sedated or adequately dilated. So they take a call on that. So the blood gas gives them a lot of inputs, and with the help of the anesthetist, they maintain it all well. Kidney being one of a very sensitive end organ, it will show that if the perfusion is not adequate, the urine output will not be adequate while the child is on cardiopulmonary bypass. So it's a very sensitive indicator, and it helps us to maintain the patient well on bypass. And also the electrolytes are monitored, like I said, sodium, potassium, chloride, and also the calcium levels are monitored. We have to make sure that complete surgery duration, the ACT is above 480. Otherwise, there will be microclots in the circuit, which you cannot make out. And then it keeps coming back. If it bypasses the filter, if it's very tiny, then there is clot and chances of embolism. Also, the perfusionist will be monitoring the reservoir level. That means whatever blood is coming back to the heart needs to go back into the cardiopulmonary bypass. So if it is dropping, then they keep alerting us that the levels are dropping. So we need to see from the surgical end what we can do, whether the cannula is in position or the cannula size is adequate or not adequate, or the amount of fluid that they're giving is adequate or not. So all these things, we have to help them out to maintain the reservoir level. Or if there's too much blood lying in the pericardial cavity, in a small child, it matters. So we need to suck and give it back to them so that they maintain their levels. The perfusionist will also ensure that the blood flow is happening at proper rate, or the flow rate. So that is calculated based upon the temperature and the body surface area, and they maintain that flow to stay as physiological as possible. So not just the quantity of the flow, the pressure at which they give also is maintained. Of course, oxygen saturation, temperature, when we are coming off, the ECG is monitored, and venous oxygen saturation is monitored to make sure the extraction of oxygen is optimal, not too less and not too more, definitely. Mean arterial pressure is maintained and monitored in relation to the mild to moderate hypothermia. So in a normal adult, we'd like to have perfusion pressure of 60 to 70. And in infants, we'd like to, sorry, that's a mistake. It should be according to the weight of the infant. It's not necessarily more than 60 millimeters of mercury. And the CVP ideally should be 0, which means the heart is completely empty. Everything is diverted into the cardiopulmonary bypass. So these are just the flow rates at which they maintain, how many liters per meter square per minute. And it is adjusted according to the mean arterial pressure and the oxygen levels.